Thank you so much. At the outset, let me thank the entire CAHO team for the honor of this podium this afternoon. Technology is all about getting new technology, and it is predominantly clinical oriented. So my talk would be predominantly technology in relation to clinical leadership. Technology and leadership is predominantly understanding the patient or the customer needs, taking advantage of the data and analytics, embracing new technologies and staying ahead or on par with the competitors, and collaborating with other institutions or organizations. AIG leadership vision has been something like this, trying to acquire the technologies that is available as in today, extend the technological indications of the acquired technology, and innovate newer technologies. There are different cons of acquiring latest technology. The latest technologies are quite expensive, they're evolving, and it is very difficult to keep in pace with the frequent upgrades that we get. And the outcomes and collaborations are unpredictable with these latest technologies that keep coming in. Is conventional leadership in technology advancement optimal, especially in Made in India and Make in India initiative? There's a lot of West to East technology implementation has a lot of limitation in the terms of cost. But you change over to indigenization, we talk about indigenous local technology development that translates to national, international visibility and recognition, and it also translates to maybe East-West technology implementation. How do we practice at AIG? We identify and recognize untapped inherent potentials of clinicians beyond their clinical practice, identify areas of clinical and non-clinical interest. We have brainstorming sessions with them, involve them in those areas of interest beyond the routine clinical practice, supplement them with specific educational courses with ISB and AIG executive programs, and we collaborate with national, international institutions and industries. A part of this, actually, a lot of things have got into clinical practice at the AIG. I'll give you a couple of examples of this. This lady actually had malignant dysphagia who could not swallow. The standard of practice was to put a tube into the stomach and feed the patient through the tube. So intense was the urge to eat that this lady used to chew the food and spit the food into the funnel that is attached to the gastrostomy tube. These tubes that came into commercial use in clinical practice were very, very expensive. For the first ever time, way back about 2 decades back, we innovated this and made indigenous processes with the help of local people in the local lathe machines, costing about 15 to 20 rupees. These we have gone through the bench to bedside technology, adaptation, make sure that these are absolutely good in quality, and subsequently we have tested them in a lot of our patients, and this was one of the standard of practices till the metallic stents came into clinical practice. Nagi stent, the lumen opposing metal stent, is one of the most widely globally used for biliary pancreatic diseases. It's a patent from our hospital, Dr. Reddy's patent. It's a metallic stent that is innovated, designed by our in-house designing done, and we got it done by the T-Wing industry, and this is one of the most promising lumen opposing stent that is available in clinical practice as in today. Inspired by this movie called Matrix, wherein the evil gets into the body somehow, but the best part of this movie is how this evil that gets into the body is removed from the body without making an incision. This is what has led to the innovation called as the natural orifice transluminal endoscopic surgery. For the first ever time, we tried to do this in animal models, intubated hen models, did transoral liver biopsies, cholecystectomies, appendectomies, and made sure that the hen recovered after this procedure. This was again subsequently translated for the first ever time, and you talk about this natural orifice transluminal endoscopic surgery, wherein without making an incision, you get into the abdomen and do appendectomy. And AIG is credited with the world's first transgastric appendectomy, absolutely scarless. Now, as a part of this, when we're trying to do this, people made mockery of us, thinking that you need some instrumentation like this, and even people made cartoons of us, thinking that it is not highly impossible task to do this procedure. But this, again, by inspired these movies like this, we extended this clinical use, what we thought was the initial mockery, and we started designing these tools. This was the first ever design that came in 2004 by the industry, and this translated into umpteen number of these newer endoscopes that came into clinical practice. To the right, what you're seeing are the newer ones which have got robotics included into these things. We're also trying to acquire endorobotics, other technologies. I'll show you a couple of examples. For the first ever time, we use this flexible endoscopic robotic system in collaboration with the Nanyang University, Singapore, in the sense that we have two flexible robots compared to the rigid robotic system that we have. And we have shown that these robotic systems, which pass the flexible robotic system, are faster, and the recovery is faster in these patients. This is the first ever flexible robotic system from Asian Institute of Gastroenterology, Hyderabad. Likewise, we have this endobrain right now, which come into clinical practice in the sense like, as in today, suppose if you have to make a diagnosis after an endoscopy, you need to take a biopsy, send it for histopathology. Now this scope, suppose if you use it in contact with the thing, it makes a diagnosis of a malignant versus a non-malignant nodule. As I'm today, I'm not saying that replaces histopathology, but in the days to come, I'm sure it's going to replace histopathology. For the first ever time, we translated this on the laparoscopy side, where we use this endobrain on laparoscopy side for a patient with unexplained ascites with multiple nodules, wherein we use this and made an on-table diagnosis, trying to differentiate between malignant deposits versus non-malignant deposits. As in today, it is helping in targeting biopsies right now. We have a collaboration that is going on with the Indo-Japanese government collaboration, umpteen number of projects. One of the projects is this ELO enhancement which has come in, wherein compared to the white light laparoscopy that you talk about, we are talking about ELO enhancement right now. The next generation laparoscopy is all about doing surgeries in an ELO enhancement compared to white light, which has shown significantly less blood loss and able to visualize structures better than what we do on conventional white light. This is the prototype that is being evaluated in AAJ hospitals. We have a lot of other things which we've seen where we have innovated the thing, including artificial intelligence. As in today, most of you will know about this ICG technology, which is used to perfuse and also help in nodal clearance. As in today, it is subjective. We just go by the color of the ICG to make sure that the organ is adequately perfused or not. But for the first ever time, we at AIG included AI into this, and now it shows the percentage of perfusion of the organ, which helps in decreasing the overall morbidity of these procedures. We also developed for the first ever time the endoscopic simulator, which is on par with any of the simulators that are available in current day clinical practice, which has got AI incorporated into the thing, and it is able to pick up lesions, and the pictures are absolutely stunning. This is all done with the help of the IIT, IISC, and AAG hospitals, and you can see the beautiful images that you get on the simulator, which are better than the 4K pictures that we get in clinical practice. We also, the cardiothoracics team has also developed artificial heart. It's an Indo-American collaboration. The initial trials are going on. I'm sure in the days to come, we'll see this artificial heart into clinical practice. Islet cell transplantation, AIG joins the islet club, wherein we are one of the first ones to do this islet transplantation in this part of the world. As in today, it is autologous, which requires no immunosuppression, but allogenic requires immunosuppression. The question that we posed to our researchers was, can islet transplantation be done without immunosuppression? Something similar to what we see in these movies like Iron Man, where you have a bioartificial heart, which does not require any immunosuppression. We had a Government of India approval, and then we were supposed to test this before we get into clinical practice. We did this on a non-human primates, wherein we had a device called Therasite, which allows nutrients to pass through, but not the immune cells. This was successfully done, and we published it, and this translates into clinical practice. Soon we are going to have a subcutaneous implant, which is going to take care of diabetes. Can we regenerate esophagus? This is the work that is going on at AAJ as of today. We have a rabbit experiment that is going on, wherein we have a scaffold, we remove part of the esophagus and try to regenerate this esophagus. Putting in a fully covered stent, a scaffold and mesenchymal cells, we're able to regenerate a centimeter of the esophagus as in today. This, I'm sure, is going to be a big translation, big into clinical practice. All this translated year after year, we seem to be getting awards and recognitions from various institutions, from CNBC, Week, Newsweek. We are very proud of this. And what does this add to? This clinician involvement increases clinician satisfaction, credibility and visibility, both academically and socially. We have about 27 patents and over 1,000 publications from all the departments. It decreased the attrition rates among the clinicians. It led to emergence of new technology leaders, and the institution recognition as center of excellence. And last but not the least, it's improving patient outcomes and satisfaction. Thank you so much once again for the patient hearing.